Hi everyone, welcome to another Wednesday VMR. Sharmin here. So excited to, chat medicine and talk medicine with you all. So excited to be joined by the one and only Sam B. How's it going, Sam?
It's going great, Charmine. I'm so excited to be here and discuss with you today. I'm so excited to hear Mitch's case. I just learned we have something pretty cool in common. Um, yeah, emergency people unite. This should be a fun day.
Woohoo! Hey, Mitch, thank you so much for joining us and presenting. In case you want to introduce yourself.
Yeah, super excited to be here. Thanks, guys. My name is Mitch. I am originally from Iowa, and I am a soon to graduate M4 from WashU in St. Louis. And then I will be starting emergency medicine residency out at Mount Sinai, in New York in a few weeks.
Amazing. Enjoy the rest of the M4 year before intern year. It's gonna be a lot of up and down, a lot of roller coaster, but a good
Vacationing it
one.
up right now.
Big shout out to Julia and Evan for scribing and doing teaching points. And if you can get the board up, we can get started. Awesome. Thank you, Julia. All right, Mitch. You gonna get us started?
Yeah, sounds good. So this is a case I saw in the SICU last year on my sub-I. And this is a case of a 35-year-old female, and the chief complaint for the emergency department was that she was brought in by EMS for an unwitnessed fall. So I'll give you a little bit more details around the event and her review of systems to hopefully give a jumping off point. So the patient had called out for help from her bathroom, and the mother of the patient actually called EMS after seeing her on the bathroom floor, and she was unable to get herself up off the ground. She described this event as a fall on the edge of her bedroom bathroom floor, and she couldn't catch herself. She says she remembers the entire event and denies any lightheadedness, any chest pain, any palpitations, or any pre-syncopal symptoms leading up to the fall. And then she also denied any loss of consciousness, any post-ictal confusion, tongue biting, or urinary bowel incontinence. She actually says that she's had multiple falls over the last few weeks prior to coming in, mainly occurring while walking from her bed to the bathroom. And she's denied ever having a head strike during any of these encounters and never sought any medical attention after any of these events. So initially in the emergency department, she was resuscitated pretty quickly and had a trauma evaluation done, which I'll get into a little later. But a further history was gathered kind of at the end of the ED stay and then by me and my team in the SICU. So I want to share a little bit more of the history there. So what we could get further from her is that she revealed that she's had some progressive fatigue and some generalized weakness over the last month, worsening the last 2 weeks where she had nearly become bedbound, pretty much only getting up to go to the bathroom over the last 2 weeks when these falls were occurring. For the rest of her review of systems, she endorsed bilateral, achy, non-radiating thigh pain and extensive bruising on her thighs and calves for the last 2 weeks after these falls began. She also reported having some progressive shortness of breath over the same time. She normally is not short of breath. Started about a month ago, occurred with minimal exertion, and now she has been short of breath just laying in bed. As far as things she denied any fevers, though she maybe said she's had some chills the past few days. She's denied night sweats, recent sick contacts, and then she denies any headaches, lightheadedness, chest pain, nausea, vomiting, diarrhea, abdominal pain, and urinary symptoms. So I'll leave it there.
Wow, this is intriguing, Sam. Thank you so much, Mitch, for giving us so much background information. Sam, what do you make of this young person's presentation?
Ah, Yeah, this is fascinating, and thank you so much, Mitch, for bringing a case that's a little more in my wheelhouse. I love a good trauma, so I'm very excited to learn more about this as we go. I think what's really kind of standing out to me is this is a young, previously healthy patient who's now having frequent falls. Um, and that is just kind of an automatic red flag for me for something more serious. And then when we kind of dig into this amazing history that your team got, um, we find a lot of really other interesting features. So shortness of breath, thigh pain, extreme fatigue, myalgias, and easy bruising. Um, and this has been going on kind of subacute period for the past few weeks. Um, And so there's a lot of boxes we need to check in this person when we're trying to rule out anything kind of emergent or life-threatening that could be causing these falls. Um, Anyone who is having falls without any prodromal symptoms or postictal symptoms will need a full cardiac workup, absolutely. Um, because the lack of any sort of pre-syncopal lightheadedness, dizziness, warmth, rising, that kind of points you against things like vasovagal or orthostatic reasons for a fall. So certainly we'll need EKG, echo, troponins, kind of that whole bucket of things. But a lot of these other things sound somewhat neuromuscular in nature as well. The bilateral thigh pain, the weakness, and then fatigue is a tough component because that can be kind of non-specific. But I'm, curious if there's been any recent illness to maybe point us at anything demyelinating. I'm sure we will eventually get some sort of head imaging. Because I mean, this could be something really severe, like a primary progressive MS picture. There's such a interesting sort of multi-system involvement as well with the lungs. So I'm, I think, yeah, let's focus first on the what would kill her first, the ED mindset, and be looking at the heart. But I definitely want to be getting a really good physical exam, especially neurologic and musculoskeletal cardiopulmonary exam and some basic labs as well. Because even though she's not having maybe any symptoms of dehydration or an electrolyte deficiency, that doesn't mean she doesn't have it. But what do you think, Charmaine?
Yeah, wow, ED powers unite. I love it. No, that was like a very, very thoughtful way of like going through some young person who's coming in fall and kind of taking a frame of like, what is your no misdiagnosis and what do you want to miss, which is like all we all need to do. I agree with you in terms of like, there are many signals, and I'm not sure the degree of them during for her presentation. In general, if I like take a step back, I learned this from the amazing Gurpreet Dhaliwal a while ago about like, when you think about fall, think about like what it takes to stand up and walk, right? Like, and when you think about the systems involved, there are many of them. Sam, you were mentioning cardiovascular, right? So that's kind of like your pre-syncope, syncope workup or the cardiac orthostasis reflex. Is it like an environmental issue that a lot of the time we see with our older folks? They can trip over things. And then you need like a good musculoskeletal system in a setting of like, your osteoarticular joints and your muscles. And then the big category here is your neural axis. So thinking about anything going from your cerebellum. That means like, are they altered? Which this patient is not. And if any like cerebral issues, that's like comes a lot of the like ataxia and stuff like that. Is it a sensory issue? Like, we see that a lot in like, peripheral diabetes, for example, or is it strength? And I think the one thing we're worried about this patient is like her strength. Basically, is there any issue with the signal that goes from the cortex to the spinal cord to the motor neuron to the nerve to the neuromuscular junction to the muscle itself, that is there anything in that axis that is like getting interrupted? Um, as when people say like, they couldn't catch themselves, I worry a little bit about more like kind of proximal muscle weakness. So this is someone like a really good neuro exam would be really helpful to kind of think about, what she says as generalized weakness. Are we dealing with like actual muscle weakness? And there is like, are we dealing with like a myopathy where it can be like more diffuse versus like a focal neurological deficits that can further explain? The other things that, I'll be tracking, and I don't know how much are within it's gonna come to be the syndrome, is like, this progressive shortness of breath and also this like bruising, which, like anemia for sure can make you feel really tired, especially if she have any issues with like coagulation cascade that, we're seeing here that is like worsening the risk of her fall. So I think like there is a lot for us to digest. I think, initial labs, a really good exam would be really helpful. And again, like, she's 35 and we're assuming that she doesn't have any like medical issues. I would be curious to know if, if this is someone who has like any congenital heart disease, anyone who has any like hereditary disorders that could help us, or no, this is like the first time this is presenting. Um, there are, oh, actually, I'll pause there before pontificating some more and get some more information from Mitch.
That was an awesome discussion. I also loved this case because it came in as a trauma pretty quickly in the emergency department. So a lot of the history and all of this like clinical reasoning came a little bit after. But I promise we'll get to the labs in a minute. But I'm going to share the rest of the history and physical exam. And I have some pictures of the physical exam to show as well, if I can share my screen. But as far as the rest of the history for her past medical history, the patient didn't interact with the medical system a whole lot in the past. She has struggled with polysubstance use disorder for the last 15 years and usually uses fentanyl, heroin, cocaine, meth, and benzos. She's been on and off medication assisted opioid use disorder and was recently on methadone 4 months ago, but had stopped prior to coming in. And then also has a chronic osteomyelitis of her left upper extremity from a chronic wrist contraction deformity that she was currently having an outpatient amputation workup with ortho ongoing. But at the time we saw her, um, there was no definitive amputation plans. As far as her meds, she's not on any meds except for being on and off methadone. She was not on methadone at the time she came to the hospital. Her family history wasn't contributory, and her social history. She's a mom and has a daughter in high school who is graduating from high school this next month. Her and her daughter lived at home with her parents and has struggled with housing insecurity in the past. And at the moment, she's currently unemployed. As far as her health-related behaviors, she has polysubstance use disorder and drinks alcohol socially, says 2 mixed drinks a week, and doesn't have a smoking history. There's no allergies. So as far as vitals and exams, she came in and looked really sick. So I'll show you some pictures here in a second, but everyone was pretty concerned in the ED. And so, like I said, this is sharing this now, but this is why a lot of resuscitation went initially. So her vitals, her temperature was 37.5. Her heart rate was 136. Her blood pressure was 86 over 48. And she was started on a norepinephrine drip in the emergency department pretty quickly. She had a respiratory rate of 24, and she was satting 84% on room air and was placed on 6 liters nasal cannula with her SpO2 rising to 94 with that. Her BMI is 24. As far as her exam, she generally appeared very sick, lying in bed. Um, for HEENT, she had significant dental caries and poor oral hygiene throughout her mouth, though no obvious abscesses that we could identify. She also had purpura and petechiae all throughout the gums in her mouth. Her very dry membranes and no exudates on the tonsils. As far as her cardiovascular exam, no murmur was heard on the exam in the ED nor on my exam in the ICU. And then no JVD was ever checked or documented. As far as her pulmonary exams, her breath sounds were diminished pretty much all throughout. There was no crackles and there was no wheezing. Her abdominal exam was soft, non-descended, non-tender, no bruising or masses. As far as her neuro exam, she was ANO times 4. She was following all commands. And I'll just blanketly say her neuro exam was very benign. She had 5 out of 5 strength in all of her extremities, upper and lower, every muscle group. Her sensation to light touch and pain were intact. Her lower extremity reflexes were all normal, and all of her cranial nerves were normal. So very benign neuro exam. As far as her extremities and skin, which is what I want to show you, she had that left wrist contraction that was against her forearm with necrotic appearing tissue between them. And then there was extensive bruising, ecchymoses, non-palpable purpura, and blistering all throughout her thighs and her calves. She also had a necrotic appearing wound on her left knee. And then I think what was very significant to us is that she had 3+ pitting edema to about the mid thighs. Um, that is what I have for her exam. And then I can share some physical exam photos if you guys would like.
Yeah, go ahead and share them. I made you co-host.
Yes. Okay,
Fascinating case, Mitch.
lovely. Can you guys see my screen? Yeah, so the
Wow.
top picture on the left is it's her right knee, sorry, not her left knee. And then the bottom picture and the ones in the middle are pictures of her calves and thighs. And then the picture on the right was a picture of her left wrist deformity.
All right. Do you want to start, Sharmin, or do you want me to jump in?
No, 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 go ahead. We can,
Okay.
thank you so much for showing us the picture. There's nothing like
Yeah.
a picture to take us to where you were. Yeah, Sam, what are you?
Yeah. The so much of what you've just shared, Mitch, both the history and the exam and the images is just so powerful. And I think the way that my entire thinking about this case changed when you said she has a history of IV drug use, I think is, it really is just kind of reframing everything for me because you have to be concerned about immune compromise and other systemic diseases that people who use IV drugs are at particular risk for. And in the setting of the vital signs and the kind of background with which she presented, um, you kind of have to approach this as sepsis until proven otherwise. And then that history of IV drug use just really kind of opens this huge box of extra bad things that could be going on. So I'm very worried about this patient. And it sounds like your team, appropriately was addressing all of these many concerning features of the case. And this is, just really a kind of a fascinating picture. Um, but I think when we kind of see this person who has, this background of IV drug use, this history of osteomyelitis, she's very vulnerable in a lot of ways. With this kind of clinical history of subacute progressive inflammatory symptoms, that is now leading to fatigue and frequent falling. The thing that kind of first jumps to my mind as something to rule out would be a bacterial endocarditis. So certainly the lack of a murmur does not rule this out. So I would be hoping to get an echo in pretty short order here to see if we can see a vegetation. Um, the other things that I'm sort of thinking about kind of on this background of polysubstance use disorder is, are there any concerns about nutrition, especially even though her strength is preserved, like maybe she's still falling and could be having balance or sensation issues. You have to be concerned about nutrition, and something that I think would kind of tie a few of these things together would be something like beriberi, which can give you this dilated cardiomyopathy. You end up with edema in the lungs and edema in the legs, and then also can cause cytopenias and disorders of platelet function and the clotting cascade. Um, so I certainly will want to be getting, I mean, I'm sure as part of the trauma workup, she essentially got CT'd from head to toe. But we definitely need to get a better look at the heart. So is this respiratory distress originating from the lung, or is it the sequela of disease in the heart? I think I lean toward, with the information we currently have, it being a disease of the heart. But I would be very eager to see the echo. And then we certainly need a pretty detailed laboratory workup as well. Blood cultures, cell counts, of course, electrolytes, a CK, just with the amount of bruising that she has. And then I would also probably be sending some of those nutritional labs. It can be, I think malnutrition is something I've been thinking about a lot recently, just with some of the patients I've had. So it's something that I think can kind of go under the radar a lot. Like it may be occurring in a patient you don't necessarily think of as being at risk for malnutrition, but I've seen it be very sneaky and cause a lot of, kind of horrible systemic inflammatory symptoms that are very debilitating. What do you think, Sharmeen?
That was such a brilliant discussion, Sam. You are ready for t tackling all the sick patients who are rolling into an ED, Sam. That was fantastic. Yeah, I'm super, Mitch, I can understand what you were so concerned about her. I'm like super worried about this patient. So, I think if we take a step back, she's like a 35-year-old with history of substance use disorder, poor to a dentition who's like coming in with shock physiology, hypoxemia, petechiae, and kind of this rapid progressive like purpuric necrotic skin. So when I like look at her exam finding, and I think what you all saying about like, norepi, resuscitation, broad spectrum antibiotics, absolutely. You just like throw it on. But I worry about like, is this like retiform purpura with necrosis? And like kind of like thinking about what causes that as you nailed it, Sam. Like the big one that you worry about is like kind of like endocarditis sepsis with that prior history of like substance use disorder. What I would worry about on top of that is well, a DIC, because it definitely sounds like, her coagulation cascade. There is like a lot of bleeding going on. Um, with the petechiae, little platelets, I would really, really worry about like whether she's in DIC. The first purpura, the mucosal bleeding, the oral petechiae, the shock physiology, I think that's something that to think about. Whenever people are presenting with this kind of like purpuric necrotic features, I think like number one, number two is like kind of infections and sequelae DIC. With history of like cocaine use, I worry about like levamisole induced vasculopathies, and especially like being associated with cocaine if she's having any cocaine active use. This is someone that perhaps like a urine tox would be helpful in kind of figuring out like which substances she's like currently using. The things that you want to look for. Like often like the face and the extremities are involved in that case, and they're like ANCA positive as well. So thinking about in the background, maybe sending that. I really loved your thought about nutritional deficiencies like vitamin C, thiamine is a big one. And I my teams hear me say this. I love thiamine. I put on thiamine like nobody's business. I'm like, it doesn't hurt. When it helps, it really helps. So like and especially with like thiamine deficiency can cause a lot of vasoplasia as well. So if that is going on, you'd see the blood pressure um, get better first before like any of the cardiomyopathies. I can get reserved. The other thing that, in the whenever I see skin findings, the one thing I don't want to miss is a kind of a calciphylaxis type of, probably not. We'll see once like a lot more labs come back. So it definitely like treating this most likely as a septic shock. The one thing that, as you give norepi, taking a close look at that pulse pressure, because, with the lower extremity edema, we're worried about like, you know, um, like cardiac physiology as well. So thinking, is this a mixed shock? Is this mostly sepsis? Is it mostly um, like cardiogenic potentially? And like, with all the bleeding and everything, you would kind of want to make sure, getting the labs and this is not like a hypovolemic hemorrhagic. The other thing that I would just say from like a lung perspective, I totally agree with you, Sam. The diminished breath sounds are a little hard to assess, and how well we hear lung sounds is uh, dependent on like people being able to take deep breaths. So whether this is pulmonary edema, the one thing in a setting of a trauma, you don't want to miss like a hemothorax. You're just having bilateral sounds, so less likely to be a pneumo. So this is someone that I'm sure in the ED, they were getting the ultrasounds to make sure like there's no big effusions there, she's not bleeding into her belly, like making sure all of those things first is done. And then going from there. So I think in terms of a workup, you nailed it. I think like a CBC to get a better sense of his blood coagulopathies would be really helpful. Like making sure to send the DIC panel with the fibrinogen blood culture is absolutely lactate. I would still send the CK just to make sure we're not dealing with like a myonecrosis of some sort. Echocardiogram. Hopefully, if she's stable enough to go to the CT scanner, she probably is going to. Um, to get it. And like this is someone that I would like start like broad spectrum antibiotics. And the other test that I would most definitely send is like an HIV test to begin with. And I think like your nutritional thoughts are valid and starting those up front, I don't think it would hurt. Any other thoughts, Sam, before we pass it along to Mitch?
Yeah, thank you so much, Charmaine. I really feel the benefit of your experience here. Just having done this so many more times than I have. I think one other point that I saw in the chat that I really liked, I saw a couple. Lyra pointed out xylazine as well for people who inject fentanyl. It's a frequent additive, and it causes these horrible skin wounds. There was just actually a scene on The Pit about that for those who watch. And then also I think testing the hepatitides as well because they can also kind of cause these kind of inflammatory vasculitides as well. But I'm so eager to hear what Mitch has next for us.
Lovely. We'll get to some ultrasound. An ultrasound probe is my favorite thing besides food in my bed. So we'll get to the ultrasound images eventually. I'll give some labs next. So I've loved seeing the chat, all the things that we were concerned about, and thinking through. So as far as hematology, her white blood cell count was 11.9. Her hemoglobin was 6.7. Her platelets were 35 and an MCV of 87. Her lactate was 4.7. And then we got coagulation labs for concern for DIC. Her PT was 18.6 with an INR of 1.7. Her APTT was 28. And then her fibrinogen was low at 159. As far as her chemistry, her sodium was 128. Her potassium was 3.2. Her chloride was 85. Her bicarb was 26, which made an anion gap of 17. Her creatinine was 1.55, and her baseline 6 months ago was zero point 0.9. She had a BUN of 51, a glucose of 107. She had an albumin of 1.4, a calcium of 7.1, and so the corrected calcium with the albumin was 9.2, and then her MAG was 1.6. Her AST was 38, her ALT was 8, and her alk phos was 166. Her Billy was 1.7, and the breakdown was zero point 0.7 direct and 1 indirect. And she had an ESR of 71 and a CRP of 301, an LDH of 359, and a troponin of 5. She got a UA that was non-infectious. It was pretty dirty. There was a lot of epithelial cells, a little bit of white blood cells, a little bit of red blood cells, and some casts, but was deemed by everybody to be non-infectious. We did send a UDS that was positive in the ED for opioids, fentanyl, and xylazine. And then we got an initial infectious workup. Blood cultures were drawn, and I will share those later. Her RVP was negative. Her HIV was negative. Her Hep A and B was negative, but was Hep C positive. Um, Yes, that is what we got. Her CK was mildly elevated, ever so mildly elevated. I don't have the exact number in front of me. So in terms of imaging, they got a EFAST exam in the emergency department that didn't show any signs of internal bleeding, did not show any pericardial or pleural effusions, and was negative. There was a lot more imaging. The donut of truth is the donut of truth for a reason, but I wanted to throw it back at you guys with these labs and to hear what additional imaging would you like. I also have videos of additional imaging that I can show next time.
Amazing. All right, Sam, bunch of labs. What do you make of them?
There is so much going on here. Thank you so much for sharing all of this so clearly, Mitch. And thank you to Simi, Magnus, and Manaswini last week for presenting their teaching points recap about cytopenias, because I'm gonna pull all of that in right now. There's, you know, pretty marked anemia and thrombocytopenia in this patient with a preserved white count. That's almost sort of high end of normal. So that's really interesting. Where the lines that really seem to be affected are the red cells and the platelets. So kind of where I will start with that is you approach a bicytopenia as if it's a pancytopenia. And so you think about, is there a problem with production? So a nutritional deficiency, myelosuppression from medications or infection, viruses, systemic inflammation, or is there something space occupying? So a malignancy or a myelofibrosis. And I may be making up this idea, but I believe xylazine can suppress the bone marrow, and hepatitis C as well certainly could. And it also could very much be possible that this woman has an undiagnosed underlying hematologic malignancy. So I'm gonna second what Han suggested in the chat, and let's add a smear. And I think the LDH and haptoglobin, because when also you have the low hemoglobin and low platelets, you think about peripheral destruction. Like a Maha picture, and endocarditis can kind of do that as well, or consumption from DIC. The LDH and the haptoglobin are sort of pushing against that a little bit in this patient. So I don't think we're seeing destruction of red blood cells and platelets, but consumption is definitely still possible. And then just looking at that hemoglobin number with what this patient came in with and what her skin looks like, the bleeding in her skin is not enough to explain a hemoglobin that low in an otherwise healthy person. And so just considering that she is coming in as a trauma activation, she will get scanned head to pelvis to see if she is bleeding internally anywhere. The EFAST is um, it's a very good test for confirming that there is bleeding, but not seeing any internal bleeding on the EFAST doesn't necessarily rule it out, because you can't very well assess the retroperitoneum, and you can't assess the inside of the pelvis very well, as far as when we're thinking about places in the body where you can lose a lot of blood. So CT is mostly negative. I'm sure if there was anything really, really important, we'll hear. And then I really like, Mitch, that you reserved the blood cultures for later, because that's just very realistic. You never know if they're going to be positive or negative in the first few hours. Um, and then kind of seeing this, let's like the low sodium, low potassium. There's a lot of things that can kind of do that. And she's got an AKI. Is it possible, these kind of the weakness, the falling, the mobility challenges, reducing her PO intake? That's very possible. And I think if this were something more like septic emboli to the kidneys, you don't necessarily see that bump in the creatinine. And if you're in acute renal failure as a way of explaining her pulmonary edema and her peripheral edema, you would expect more of an elevated potassium as opposed to a low potassium. And then when I look at the liver function tests, she's got more of a cholestatic pattern, which is interesting to me in this person with a lot of risk factors for hepatocellular disease. But what can happen with long-standing liver disease is you no longer see those elevations in the transaminases because the liver is just out of stuff. So I don't know that we can rule out a hepatitis in this patient. She is hep C positive. It's kind of hard to say. I didn't hear anything on the exam or notice anything in particular in the pictures regarding stigmata of cirrhosis, but I feel like in a patient with all of these abnormalities, I just kind of will assume a bit of a baseline hepatic synthetic dysfunction until you see otherwise. Um, and then yeah, she's pretty inflamed, as we'd expect. I think the mild CK elevation can probably be explained by her falling and the bruising under her skin. So less concerning for something like a rhabdo picture, for being down for a long time. And then yeah, that lactate makes a lot of sense to me, just given how systemically ill she is. That's pretty much in line with what I might expect. The elevated INR is making me think more about hepatic synthetic dysfunction. And so other things I think I would want, always in a hep C positive individual with some sort of rash that could be construed as vasculitic, you want to send cryofibrinogen and cryoglobulin. I would probably send all the like ANA, ANCA, all the vasculitis things just in case. And then I think the other thing to keep in mind is that an EFAST also can't rule out bacterial endocarditis. It can't rule out definitively a vegetation. So we do need a formal echo and possibly a TEE at some point as well. So I think that's where I might go from here. What do you think, Charmaine?
Sam, that was fantastic. I really, really loved how you were approaching the cytopenias and thrombocytopenia and like thinking about like the each buckets. That's a really, really great way of like thinking about it.
It's all thanks to the group from last week.
Hey, medicine is a group effort. I will die on that hill. It's a group effort. Um, yeah, I continue to be very worried about this patient. If I like take a step back, just layering on your beautiful assessment of like all the lab abnormalities, like what jumps out to me is like you're right. This patient is very inflamed, and I worry this patient is in DIC. Oftentimes, when I see this, like low platelets that are in an acute setting, yes, sepsis can cause like myelosuppression, all of those things. The first things when I say thrombocytopenia, I hold my breath. Two things. I'm like, is this patient has hit? Is this patient has any MAHAs basically, microangiopathic hemolytic anemias are like my two no misdiagnoses when it comes to platelets. And I'm like, oh, hit probably less likely in this patient. This DIC for sure in this patient. I'm worried about. So this is like a thrombocytopenia in the setting that I would take very seriously. And when you kind of look at the other lab abnormalities with the elevated INR, PT, low fibrinogen, elevated LDH, and the clinical signs of like bleeding with the low hemoglobin and some thrombosis that is happening on her skin, most likely if this is like retiform necrosis, then I'm like, okay, I'm worried about a consumptive coagulopathy with like kind of maybe bleeding and probably some clotting that is happening, which is kind of a hallmark of a DIC. And then the question becomes like when you are worried about DIC is oftentimes driven by something. And in this person who is like super inflamed, what I worry about like is it driven by, as you mentioned, like severe sepsis, and for sure thinking about like endocarditis, like bacteremia, endocarditis, and thinking about whether those like hypoxemia are those septic emboli to the lung or pulmonary edema is secondary to cardiac complications of it. So, she has a couple of reasons. She already we know has, in terms of like, okay, what could be the source of her infection? Um, yeah, the UA is always challenging, Mitch. Is it true? Is it not? The good news is like we're gonna put her on broad spectrum antibiotics, but I think a couple of things. She has like skin wounds that could potentially be an opening for a staph strep type of infection. We know she has a chronic osteo, and if anything, her immune is suppressed. Could that be the source? Substance use. For sure, another risk factor for her. And then like the dental caries is another one that, Mitch, and also like great job taking a look at her mouth and also like not forgetting about that. Um, the one thing about like the xylazine that is positive, the xylazine might explain kind of the large necrotic ulcers and the eschars. However, it doesn't really, for me, explains like the shock, the DIC, or the systemic inflammation to this degree. Although like I might be missing something in my illness script of that. So it could be superimposed, but I think like what I would worry about is like this is a 35-year-old coming in with DIC secondary to most likely an infectious. There are other like malignancies, other things that can do it, but in like someone we're getting like so many signals for so many signals that she is septic. That would be my first round. I would love a TEE in this person. I mean, you can always like start with a TTE, but if it's TTE negative in someone that I have a high clinical suspicion would not be enough and looking for vegetation. I think a CT chest would be helpful to better understand whether we're dealing with like kind of septic emboli, pulmonary edema, or like a bad pneumonia. I don't know. So I think like that would be helpful. And then what I would do management wise, resuscitating her, giving her blood, and also kind of the DIC management. If the platelets are dropping less than like 10 to 20 or bleeding, you want to give them a bar, thinking about cryo if fibrinogen hits less than 100. And then the most important thing when it comes to DIC is just like managing the underlying disease. So as much as you can continue hemodynamic support with like frequent lab monitoring. So, yeah, that's where I am. Sam, any other thoughts?
Sorry, issue with my screen. I don't have anything to add. Thank you so much for synthesizing everything. I'm eager to hear what we have in the next aliquot.
Okay, without further ado, I'll give some imaging, and I'll go through some of the imaging that you guys wanted to get. I will just upfront say an EKG was obtained in the emergency department that showed sinus tachycardia, and nothing else, no evidence of an NSTEMI, STEMI, or any widening of any of the intervals. And a CT head, like Sam said, she came in as a trauma to the emergency department, so every portion of her body got scanned. She got a CT head that did not show any intracranial hemorrhage, any large mass or midline shifts. And then also got some x-rays of her legs because of the pain and bruising that did not show any fractures, abscesses, or anything else, negative x-rays. So now I will go ahead and share my screen and show a chest X-ray that she got, and then as well as the chest CT. And you guys can go ahead and comment after them if you would like. Let's see. Can you guys see my screen?
Yes, with
Okay.
seeing her skip findings. Yeah.
Here is her chest X-ray. Would you like me to go on to the CT scan?
We can also kind of take a look at the chest X-ray together if you want, Sam. Is there anything that in the X-ray is jumping out to you?
Yeah, I think if I had tried to like imagine what a chest X-ray would look like in a patient like this, I think this is pretty much what I'd picture. Um, where she's got quite a lot of these sort of patchy opacities pretty diffusely that look like edema. And then, a lot of different areas of what look like consolidations. I think particularly the left lower lobe looks, consolidation, maybe a little bit of an effusion. It's kind of hard to tell. Maybe a little bit of consolidation sort of in the right middle lobe. But I don't see any of like the big scaries. So trachea is in the right place. There's no pneumothorax. I don't see any obvious fractures. The heart looks like an okay size. The mediastinum is an okay width. There's no hemidiaphragm elevation. So this just sort of supports she's got some pulmonary edema. Still not really sure where it's coming from or why she has it. But that's, I guess, kind of what you'd expect. And like the role of the X-ray and sort of evaluating that we know is not going to be of the greatest utility. It's just going to be eliminating other causes of respiratory distress and hypoxia.
Yeah, absolutely. Sam, I totally agree with to me, this shows like kind of a bilateral, like diffuse bilateral kind of patchy opacities, airspace opacities. There's like no focal, like lobular consolidations, no large effusions. The left costrum finding angle is like a little bit blunted, but I think that's more like opacities rather than effusions. And like what you could imagine, like, septic emboli, a multifocal bacterial infections could look like this. So I don't think you get more than just like patchy bilateral opacities from this one. And ruling out the scary things as you amazing ED folks tend to do. So I can just focus on the parenchyma. All right, Mitch. Can't wait for
Lovely.
the
I have
CT.
two CT scans. So the first one is going to be of the lung windows, and then the second one is going to be of the CTPE or angio protocol. This is of the lung windows. And then I can also show the CTA, and we'll talk about the CT results altogether. This is the CTPE.
Wow, thank
All
you for
right.
sharing.
Yeah, Sam.
Truly, truly worth a thousand words. Um,
Yeah. What do you make of the CT?
I hate it. It's not good.
Accurate, accurate, accurate.
Yeah. Um, I mean, you see redemonstrated a lot of interstitial edema, which again, not surprising given the X-ray findings. But I think the really scary thing that has a lot of people freaking out in the chat, and me too over here, is these kind of widespread cavitary appearing lesions affecting all of the lobes, just generally looking um, quite bad. And so I think in a patient like this, kind of looking at the whole picture, septic emboli are certainly on the list, probably top of my list. But I also think, a question mark immunosuppressed patient, even though HIV is negative, I just never quite trust that people with this kind of, severe multi-system dysfunction don't have something else immunosuppressive going on. I would probably also be just you send the TB, you send the PJP. Um, yeah. Um, Yeah, and as Hans is saying, other like cavitary fungal lesions, so like aspergillus, I've seen like aspergillosis in endocarditis patients. It just kind of likes to hang out on those damaged valves. Yeah, I'm I'm really scared for what those blood cultures are going to show us that Mitch is astutely hiding from us until the right moment.
Yeah, Sam, I totally agree with you. You see like it's like multiple bilateral like nodule with cavitations. So cavitary lung lesions and like they're like peripherally if I'm not mistaken, if I remember correctly, like a lot of them are like more peripherally distributed. So it makes like kind of these wedge-shaped pleural based ones. Kind of what I would worry most about as you're mentioning is kind of like septic pulmonary emboli to the lung. For the CT angio, it was like going a little bit in and out, so I think I might have missed some of it. There was one area that I was like, "Oh, is there a filling defect?" But Mitch, to be honest with you, I've never been really great about the CTPE. I wouldn't be surprised if she has some pulmonary emboli, if especially in the setting of a DIC. But I don't, I couldn't really would definitely comment on the CT PE protocols. I would love to hear your thoughts, Mitch, about what you all saw. But yeah, I think like, uh, what that does for me, like those CT, I'm like, okay, getting that, worrying about the kind of bacteremia complicated by endocarditis. So it really makes me want to get a TEE and a TTE to begin with, antibiotics. And I think in terms of like the other abnormalities, like other potential cavitary lung lesions, absolutely, like fungal pathology. I think I would like start treating if she gets sicker, then I think adding antifungal makes sense. But if she's holding steady with like bacterial treatments, I think like I would see how she evolves, and then if she's getting worse, thinking about like other pathologies at that point. Yeah, what did the CTP show, Mitch?
Yeah. So the CTPE, I'm also horrible at with the PE protocols, CT scans in general. But my attending in the radiology read was segmental and subsegmental emboli in both lungs. So the whole CT read was bilateral septic appearing emboli in both lungs.
And that is fascinatingly challenging, right? So, how do you think about that, Sam? Like she has PEs as well.
Yeah, I think um, kind of to tie it back to our earlier discussion, she certainly, I mean, this could be, she's throwing emboli from a vegetation in the heart, and then sepsis, DIC, it all kind of snowballs. And then you end up with this bleeding, clotting equilibrium being really thrown off, plus the infection that is going to make all of it continue to worsen. Um, so I think that's kind of my leading theory without having had blood cultures or echo. Um, there's other things that I guess could cause multiple peripheral pulmonary emboli. So hypercoagulability of malignancy, certainly. Um, and I guess that's kind of
Yeah.
my other thing to maybe rule out. So, and then
Yeah.
I guess I would also worry about like maybe do we need to get like a CTA of her brain? Like, is she fatigued and falling because she's thrown clots to her brain and she's got an abscess in there? Like, I, you know, thinking about also like she's got this kidney injury. Do we need to look at the kidneys again? Is she having just kind of global septic emboli to anywhere something like that could embolize? I think just very, very concerning picture
Yeah.
overall.
Yeah, for sure. And I think like clinically management is tough, right? Because we see PE, we often anticoagulate, right? And we worry she's hemoglobin of 6, platelets of 30. So we're not doing that. But I think like something that you always like want to keep in the back of your mind as you're like managing this patient as well. One thing that I would be looking closely at her oxygenation. With like subsegmental and segmental, I worry more less about like right heart strain. But like I think you can get your trial BNP, get your echocardiogram. And in this case, just for risk stratification, I would also just get bilateral DBT ultrasounds. They're easy to get. Mostly I just like want to better understand like if she has really like proximal like DVTs that could potentially embolize. She already has septic emboli, she already has PEs. Like she might not handle more assault to her lungs. So is this someone that, for a short period of time, you would put that IVC filter in? So mostly to prevent and then like take it out because we don't like IVC filters. But I think like I'm hopeful that like, in a setting of like if we're right and treating the underlying cause, hopefully restoring the, as you mentioned, like a coagulopathy that can get better. And I'm not sure how much of the PEs are contributing, how much of the septic emboli, probably both to her oxygenation, but like something to keep in mind and kind of like assessing the burden of the PE, but like better understanding his effect on the right heart, where else she's clotting, if she has like proximal clots bilaterally, just so you have contingency plan in case she becomes worse, is what I would do at this point. All right, back to you, Mitch.
Lovely. Okay, so I will share the rest of her hospital course with our team in the SICU and her diagnosis, as well as show a final image of a test that you guys have asked for. So the ED had started her on broad spectrum antibiotics, vancomycin and cefepime, gave her a 2-liter fluid bolus, and then had to start her on norepinephrine for her blood pressure, and then was admitted to my team in the SICU for presumed septic shock. Um, Late on day one of her admission, after I had already left for the day, her blood cultures grew MSSA, methicillin sensitive Staph aureus. And then the next day, we were able to get an official TTE, which I will share my screen and show a quick snippet of what that TTE showed. This is not the full thing, but this is a quick video of the showing a large vegetation on her tricuspid valve. This is her tricuspid valve on the right side of her heart. This actually like popped up. I have Epic on my phone, and I was at home watching TV, and I saw that the like result had resulted, and so I saw this on my phone the night before I went in the next morning. So I'll kind of give the rest of her case resolution. So the diagnosis ended up being infectious endocarditis of the tricuspid valve, complicated by MSSA bacteremia and septic pulmonary emboli. We got that TTE and then an official TEE the next day. Ended up officially being read on the TE as a 3.1 centimeter by 1 centimeter anterior leaflet valve with severe tricuspid regurgitation and a dilated right ventricle. What I really loved about this case is this became an incredibly multidisciplinary care with a pretty lengthy ICU stay. I was able to take care of her throughout her entire ICU. So infectious disease was consulted after 48 hours. Repeat blood cultures also only showed MSSA. So after 48 hours of a second cultures only showing MSSA, the vancomycin and the cefepime was narrowed to oxacillin. I learned on this case that oxacillin actually has better bactericidal activity against MSSA than vanc. vanc. So infectious disease was wanting us to pull the vanc off quicker than our ICU team was because we weren't convinced that there wasn't an underlying infection, a secondary infection going on. So that was a good learning point for me about oxacillin. And then throughout the course of her hospitalization, she was successfully weaned off the norepi pretty quickly and the supplemental oxygen with an improvement in her AKI. She was also started on nutritional supplementation of multivitamin, thiamine, and vitamin C due to concern for nutritional deficiencies playing a role. And the bruising and the rash got better throughout her ICU stay. And then, given the concern for multiple different infectious sources, really seeding the endocarditis, including the left extremity osteomyelitis, the poor dentition, orthopedic surgery, oral and maxillofacial surgery, and CT surgery were all consulted and really planned a comprehensive surgical plan about what was going to happen. And so the plan ended up first going with MOMFS for dental removal and then went with ortho a week later for a left upper extremity amputation. And then later in the hospitalization, a tricuspid valve replacement formed by CT surgery. Initially, I also learned in this case that right-sided infectious endocarditis is usually treated medically first, but she came in as a class 2B for surgical indications and then was upgraded to a class 1 because she remained bacteremic on blood cultures for over 2 weeks and ended up having a fever. So our surgery team thought that given the severe tricuspid regurg and the persistent blood cultures, that a surgical operation was the best management. And then, unfortunately, this is another case that I see a lot and really frustrates me is that due to a history of intravenous drug use, she remained inpatient for her entire antibiotic stay. So she was with us for 6 weeks and then was subsequently discharged to cardio and ID for Hep C treatment and restarted on methadone when she left the hospital.
Wow. Thank you so much, Mitch. I'm so glad, that this patient ended up having a good outcome. I hope she was able to make it to her daughter's graduation. Good, yeah, and I'm glad she had someone like you caring for her whole course. Just yeah, incredible case, so rich with learning. And I think a really great illustration of kind of the multi-system downstream effects of endocarditis, and just how complex that management needs to be. Yeah, and I'll echo the treatment teaching point you brought up where I always find it helpful to remember, and this is very med student step one, step two thought, but the thing that makes Vanco especially effective for MRSA is it specifically requires that altered binding site that is only present in MRSA. So it doesn't work as well for other non-MRSA staph infections. So it's always good to keep that in mind. And whatever infectious disease tells me to do, I do. So
They're the bosses for sure.
Yes.
Mitch, this was an incredible case. I'm so glad that she's doing well. Thanks to all of you taking care of her. Great job presenting. That was a kind of a masterclass of how you presented every aliquot and like took us with you on every path that you were on. That was like really, really fantastic, and I really appreciate it. Um, and yeah, I was worried like that big of a vegetation that she wouldn't clear her cultures and, getting CT surgery involved earlier than later. Really great call on your part. And I share your frustration with, unfortunately, these patients uh, having to stay inpatient rather than getting a pick and like, going to their next place. A frustration I see and share all the time. And one question for you. So she didn't get anticoagulated, correct? Or did she end up getting?
No, I was also going to comment. So she didn't get any of the vasculitis workup just because
Mhm.
she improved with the norepi and the oxygen pretty quickly when
Mhm.
antibiotics were started. And then she was not on any anticoagulation. And then in terms of imaging, we did not get a CTA or an MRI of the brain because there was no focal neuro deficit, and she improved pretty quickly in the ICU. It was really just waiting for this multimodal surgical plan was what a lot of it was. So because of the quick improvement, there wasn't any further imaging of her kidneys or of her brain for other emboli.
Yeah, I would 100% agree with that. Because oftentimes you might find this small myocardial aneurysm and then nobody wants to heparinize for a CT surgery they need. And I'm like, well, she has no focal deficit, so let's leave it at that. No, great job taking care of patient. Thank you so much for sharing. Please come back and share more cases, Mitch. I really appreciate you. Really wonderful job, Sam, discussing and dissecting this case. And big shout out to Julia for ferociously typing. And Evan, we're ready for you for teaching points.
Yeah, great case. It was so fun to listen to all of this. So many teaching points I feel like I missed, but I hope I got the majority of them. Starting out with the falls the patient was having, talking about if there's no really pre or post symptoms, we really want to get a cardiac workup because these lack of symptoms is kind of pointing us away from any vasovagal events, and then really discussing the all of the different buckets that go into what causes falls. We have cardiac, environmental, the MSK, and then our neuro axis system. All of these really working together that can lead to a fall. Then moving forward, kind of going into the history of the IV drug use made us a lot more concerned for any immunocompromising the patient. And after the amazing skin pictures we saw in the peripheral with the necrosis, thinking more like endocarditis, DIC picture, and still wanting to nutritional deficiency, something we never want to miss in patients, and it's a lot more unexpected than we would see, especially for thiamine. Then we got to hear the great approach for working up bicytopenias and how this is typically done thinking as a pancytopenia workup. We want to think about bone marrow failure and increased peripheral destruction in patients. And if we're really thinking about DIC in patients who do have like a septic appearance, we want to look for the source of infection. So many different ways to go with UA, looking at the teeth, looking at cardiac workup. And then after the images, we kind of got onto the widespread cavitary lesions in the lungs, thinking these are more septic emboli, immunocompromised, like fungal infections, and wanting to work those up more. And then in a patient with pulmonary embolisms, we wanted to check out the rest of the body to assess for any further insult that could be happening to see if this patient can do well in the future. And then just the last part is that Vinco is not ideal for the MSSA due to the lack of the altered binding site. That was something I haven't heard before, and I think that's really good. Infectious disease, infectious disease, that's really good. And that's all I got.
Awesome. Thank you so much, Evan, for highlighting the more salient teaching points of this case. Love the summary. Thanks all so much. Really appreciate you. Thanks for hanging with us. We'll see you tomorrow. Thanks all. Bye.
Thanks.